We reached 100 participants, so I would start. Good afternoon and welcome to all of you to the first of our 4 Women's Winter webinar series on women's mental health. My name is Professor Arianna Di Florio. I'm leading the reproductive mental health program at Cardiff University. Today's webinar is dedicated to reproductive aging and mental illness. You'll hear an introduction from me, then from Lisa Shitomi-Jones, and then from Dr. Clare Dolman. Claire, Lisa, would you mind introducing yourselves?
Yes, so thank you, Arianna. And thank you so much for introducing me. As you said, my name is Lisa Shitomi-Jones. I'm a researcher and PhD student here at Cardiff University. And yeah, I'll be sharing sort of the research that I've done so far and hopefully the directions that I'll be going in the future. So I'll just hand over to Claire.
Hi, my name is Clare Dolman and I'm a mental health researcher with lived experience, and I'm also involved in various mental health charities, which I'll tell you about later.
Thank you, Lisa and Claire. So as I said, I'm going to give you a short introduction about this topic. Let me see if I can share my screen. Can you see this all right? Excellent. So menopause is a very hot topic at the moment, and no pun is intended here. It is everywhere in the media, on websites, blogs, newspapers, TV. Everybody's an expert and everybody has an opinion. Opinions are often polarized. It's either a thing or it's not a thing. And in a hypochondriac society like the one we live, the topic is often presented in very pathologizing terms, very medicalized, very anxiogenic language is usually used. And of course, people have started to exploit financially the widespread interest and fear. You get all sorts of supplements, medications, phone apps, and self-help books. This morning, I searched Amazon to see what books are around, and there were thousands of hits, and these are only the top hits that I found on Amazon this morning. And as you can say, everything is the definite guy, the positive. There is this ultimate type of messaging, and again, very medicalized, and in my opinion, also quite, again, anxiogenic. Today, really, we have more questions probably than answers, and we will try to explore an aspect of reproductive aging that is often trivialized, either in a way that everybody has it or nobody has it, and this is mental illness and the association between mental illness and reproductive aging. For this webinar, I'll use the terminology of the executive summary of the stages of reproductive aging workshop +10 and focus on the perimenopause and on the early postmenopause. For perimenopause, we mean the time around the menopause, which is itself defined as the final menstrual period. In terms of menstrual cycles, this period is marked by increased variability in menstrual cycle length, usually followed by long periods of over 2 months without menstruation until the periods stop completely. I note that bleeding criteria exclude people who have had a hysterectomy or endometrial ablation. Reproductive stages in these people can only be assessed using endocrine markers. The criteria might also be difficult to apply to those with polycystic ovarian syndrome, those with chronic illnesses, or those undergoing chemotherapy. So here we're talking about, let's say, a standard, like only we are excluding some parts of the population. The perimenopause is characterized by marked and often unpredictable hormonal fluctuations. Here are some examples of how reproductive hormones change daily within an individual and between individuals over time. As you can see, there is no regular pattern that can be identified, definitely not easily and readily identified. The highly erratic hormonal levels reflect an increasing proportion of cycles without ovulation, with a trend towards fewer phases in which the progesterone is increased, variable levels of a hormone called FSH, and both states of too much or too little estrogen. This erratic hormonal environment may extend over about 5 years, according to this paper by Gordon and al., which I recommend if you're interested in the topic to read. But what has this to do with psychiatry? This is about hormones, about ovaries. What has it to do with psychiatry? And this is when things get a bit complicated, because we know that a good proportion, over 50% of people going through the menopause experience neuropsychiatric symptoms, most commonly hot flashes, which themselves can be considered a neurovegetative symptom, but also more classical psychiatric symptoms such as depression and insomnia. But, and these get very controversial and complicated in my opinion, are these manifestations of a pathology, of an illness? Can we say this is an illness? And if it is an illness, what is it causing it? Shall we medicalize these symptoms? Do they require treatment? And if yes, what type of treatment do they require? Do they require hormones? Do they require psychotropic drugs? And is that even the distinction between hormones and psychotropic drug a valid one? If we look to the population level, these symptoms occur on a spectrum of severity. And so black and white answers don't work, and also answers need to be individualized because all people are different. The mechanisms are likely to be very complex and different in each person. And while hormones might play a role, in a neoliberal society like the one we live, I believe psychosocial factors do play a role too. And of course, the very complex mix between biological, psychological, and social factors varies from person to person. My concern about psychological factors and psychosocial factors more broadly, which I think are really overlooked by the medical community, rises from data on the antidepressant prescriptions, which is increasing. You know, like we prescribe more and more antidepressants. And to provide you some context, this is a table that doesn't talk about menopause. It does talk actually about women aged between 15 and 44. And this is the number of prescriptions that we had in the past 12 months by GPs in the UK. And this is on a population base of a bit over 11 million people, which means that about 20% of women need at the moment, as we speak, have been prescribed antidepressants by their GP. So it's not a lifetime prevalence. It's like right now. And I think this number really, the first time I read about this, I was quite shocked. And it concerns me a lot. And I really would like us to stop and think about a society that where 20%, 1 in 5 women need antidepressant medication on a regular basis. I think, is this the society we want to live in? And is this use of antidepressant necessary? This is connected with another issue, which here the picture on the left shows you, which is the risk of stereotyping women and falling into old beliefs about hysteria. You know, like we have this tradition, to link women with their hormones and their moods. And this is just, I wonder whether this is just a new repackage for the new millennium. And the risk is quite high because we know very little about this and we talk a lot. I think we talk too much, consider what we know about this. And this is a literature research that I ran last summer. It was in July when I ran this. And as you can see, there are over 100,000 papers about schizophrenia, about bipolar disorder. We have a lot of papers on this topic. But when we look how many of them also talk about menopause and use the term menopause as a medical subject heading, we found, and this was July, only 133 papers. which is quite little. But then if we look even further, we notice that the majority of these papers are actually do not contain any original data. They are just reviews, case reports, and very little evidence about this. And this is really this thing that we know little to nothing about, the perimenopause and mental illness, is what actually led to the research that Lisa is going to present now. And the main question for me was, the key question was like, is the perimenopause really a period of increased risk of mental illness? So to answer the question, we run a study that Lisa is now going to present. Lisa, I leave the stage to you.
Thank you so much. I'll just share my screen now. Yes, so thank you so much, Arianna, for introducing me. As I said before, my name is Lisa Shitomi-Jones. I'm a researcher here at Cardiff University and have the pleasure of working under Professor Arianna de Florio, working on menopause and mental illness. So I'll be talking through the research that I've conducted so far, and also we'll later be sort of mentioning maybe the direction of future research that we hope to be taking. So first of all, what is perimenopause? So I won't dwell on this too long. You've already had a quick rundown from Arianna. But just very briefly, as Arianna mentioned, the sort of criteria that we have at the moment was derived by a group called the Stages of Reproductive Aging Workshop, which is a group of researchers and clinicians who came together to sort of standardize the sort of terminology that we use, because as Arianna said, there's a lot of talk in this sort of area and very little clarity on the terminology. So to hopefully simplify it, I've made this just blue bar. This represents the stages of reproductive aging. Disclaimer, it's not to scale, it's just so to make it simple. But the sort of initial reproductive stage begins at the first menstrual period. So in women in the UK, this is typically around 12 years of age, although this varies quite a lot even within the UK, but also between countries. And the reproductive stage lasts up until the menopausal transition. So the menopausal transition, a lot of people will experience symptoms such as hot flashes, insomnia, changes in mood. But as Arianna mentioned, the sort of actual clinical criteria for it is in women that do have a menstrual cycle is variation in cycle length. So the menopausal transition begins when there's at least 7 days of variation between consecutive menstrual cycles. So this lasts up until the final menstrual period, which means someone will have a menstrual cycle and then at least 12 months of no more menstruation. And that's sort of typically when people say that menopause has happened. And that also marks the beginning of the postmenopause. So perimenopause literally just means around menopause. The sort of clinical criteria that we now use defines it as the menopausal transition plus 1 year after the final menstrual period. So there's several different reasons for this. Part of the reason is that it can be quite helpful because obviously you don't know you've had 12 years with no period until you've 12 months after the fact. But it's mainly to do with the sort of other physiological changes that your body is still going through. So this just shows 2 of the sex hormones, FSH and estradiol, and how the average levels change in reference to the final menstrual period. Just to clarify that the graphs that Arianna showed that showed very big variations in hormones are the sort of day-to-day levels. So if you take a snapshot on any given day, it's not actually a very good representation of the average levels, which is what this graph shows, which is that on average, from before the final menstrual period to after, FSH increases and estradiol decreases. But as Arianna pointed out, the day-to-day fluctuation is very unpredictable, and is actually what also we think is a primary factor that causes a lot of the symptoms that people experience. So, this also is a primary driver for a lot of the symptoms, which include things like mood changes. However, despite the fact that we know that menopause is associated with changes in mood, and some studies have looked at depressive symptoms, there's very, very little research, if any, looking at sort of clinical diagnoses of psychiatric disorders around menopause. So this is where my research comes in. So the research question that sort of I've been working on so far is perimenopause a time of increased new onsets of mental illnesses compared to the premenopause? So just to clarify, this is new onsets, meaning these people have not had that disorder before menopause. So for example, people that have a new diagnosis of bipolar disorder, having never had it before, and who experience it for the very first time at menopause, which is, as you can imagine, very sort of clinically important and typically not discussed very much in the literature, which often will just sort of give you an average age of onset and not much nuance around different life stages. So just to also illustrate, the sort of period of interest that we're looking at is perimenopause, but just to show that we're comparing it to premenopause, which in the context of my research is 6 to 10 years before the final menstrual period. And then I'm also looking at sort of postmenopause as a bit of a control group, just to make sure that it's not just an association that, for example, increases with age. The disorders that I've investigated so far include major depressive disorder, anxiety disorders, mania, which includes bipolar disorder, and schizophrenia spectrum disorders. And yes, so one of the main drives of the research I've been doing is really trying to look at clinical diagnosed mental health conditions, rather than just sort of defaulting to depressive symptoms and other terms that previous literature has normally been limited to. So for methods, I started off, first of all, using a data set called UK Biobank. This is collected from participants across the UK, and data was collected through a variety of different methods. So they all came into an assessment centre, had an interview with a medical professional, but there was also sources of data, and they include things like questionnaires. And because this is sort of like a nationwide study, the initial sample was 500,000, but this includes like men and people that obviously weren't included in our study. So after restricting to those who had who were female and who had data available for the data that we needed, our sample size was 137,000, which is still quite a lot bigger than sort of the previous literature that looks at depressive symptoms and other mental health issues around menopause. We then extracted diagnoses and onset ages from the data, and then calculated incidence rates at those different reproductive aging stages. So this graph shows the number of onsets as a density plot. So the area under the curve is not representative of the number of cases for each disorder, just quickly. Yeah, this shows the sort of number of new onsets relative to the final menstrual period for each of the disorders. Psychiatric disorder just means that they're all of them combined. So as you can see here, they do actually show slightly different trajectories, but all of them do sort of seem to have this like bump at age of final menstrual period. This is particularly true for mania, which is this sort of light blue line up here. But yeah, it does seem to be present, at least to some degree, for all the disorders that we looked at. So then when we sort of test this association statistically, this is what we see. So this grey line essentially represents the rate during the premenopause, so the control rate. The sort of blue dots show the rates, the like rate ratio at perimenopause, so the time that we're looking at, and then the control group is the light pink, which is the rate at postmenopause. So as you can see, that line that we saw at mania remains very much significant. The line are the 95% confidence intervals, so because they don't overlap with the grey line, they are significant. This is also true for major depressive disorder, which is similar to what previous studies have found with depressive symptoms. And for anxiety disorders, the rate seems to remain elevated after menopause as well. But yes, so for what we've been looking at, we're particularly interested in this mania result, which shows that rates of conditions such as bipolar seem to increase in those that have never experienced it before around the age of menopause, and then returns back to baseline afterwards. So that's all the results I have. I'm actually going to throw back to Arianna, who will be discussing the clinical implications of the results that we've found so far. So thank you.
Thank you, Lisa. Wonderful. Again, stop me if you can't see or if there is any issue. So we were interested in the specific link with mania because we in general were really interested in bipolar disorder, but we found in general perimenopause, so the period around the final menstrual period, those 4 years around the final menstrual period, do represent a period of increased risk of new onset of psychiatric illness for women without any previous psychiatric history. So these are people that have never suffered with any psychiatric illness. They've never seen, like a GP or a psychiatrist because of mental health issues. And around the final menstrual period, they develop for the first time psychiatric disease. So there seems to be an association between perimenopause and psychiatric illness, as we said, we asked at the beginning. What is still interesting is that, like, to me, it was interesting to try to disentangle whether this is due to, like the aging process, or is it something specific for perimenopause? And we do see that for major depressive disorder and for mania, this increased risk around the perimenopause seem to be specific for the perimenopause. So women that have not developed any major depressive disorder or mania by the time they reach the postmenopause, their risk of developing a new episode, the first episode of mental illness, is similar to that in the pre-menopause years. So the link seems to be quite fairly specific for those 4 years around the final menstrual period for affective disorders. I must say, I'm not sure what's happening with depressive disorder, and I wonder whether we observe a decrease because most people do get a disease in the early in their life, but I'm not sure. I would want to know something more before telling you something definite. While I feel for mania, the evidence is quite robust. You see here the confidence interval, which is the long bar, is a bit larger than for mania than for major depressive disorder, just because the disease is less common. Interesting, anxiety disorder, they seem just to increase with age. So yes, the perimenopause is people are higher risk of develop new onset anxiety disorder, but that's continue also in the postmenopause. So the link doesn't seem to be specific for those 4 years around the final menstrual period. For schizophrenia, I think it's an interesting one because there is the widespread idea that actually the perimenopause represents a period of increased risk of new onset schizophrenia spectrum disorders. This is not what we found here. And I think we should distinguish between disorders that people that already have the illness and have a high risk of a recurrence or a relapse around the perimenopause, and people without the conditions that develop it out of the blue. And I think here we're talking again about new onsets, and I don't think we can say that for schizophrenia. And there is a review paper that a meta-analysis of various incident studies that also seem to indicate that schizophrenia there is not an association between first onset schizophrenia, so new episodes of schizophrenia, and the perimenopause. So as you can see, when we talk about mental illness in relation of the perimenopause, or the, like, first of all, we need to say, is it perimenopause or is it postmenopause? That's a different phase of life, a different stage of life. And second, not all disorders are the same. So we will need to distinguish between major depressive disorder, between anxiety disorder, between mania and as a start of a bipolar illness and schizophrenia. And I think this is really important in the clinic to know that we can't consider all psychiatric disorders the same. What is interesting about mania, and I find particularly fascinating, probably I'm biased because I study bipolar disorder in women, is that we observe a similar specific relationship between mania and another reproductive trigger, which is childbirth. Childbirth is actually a way more potent trigger for mania and bipolar disorder than the perimenopause. If you see here the relative risk, which is not a risk ratio, but it's quite a similar, statistics, is much, much higher for than what we observed for the perimenopause. And this is true in gray. You see, for women with history of bipolar disorder, they have a very high risk of becoming unwell in the first few weeks after childbirth, but also for women without a history of bipolar disorder, so out of the blue developing bipolar disorder. So I would say that what we observe here is quite similar to what, apart from the schizophrenia bit, for the bipolar here, I'll focus on what we observe in the perimenopause, only magnified a lot in terms of effect sizes. How does this translate into clinic? So in Cardiff, we have free of charge UK-wide second opinion service for women's mental health, and we see women with mental health problems associated with the menstrual cycle, with childbirth, but also with the transition to the menopause. But also sometimes we've got referrals for women in the post-menopause, and we provide second opinions. So these are one-off appointments or sometimes 2 consultations. And we don't accept self-referrals, so women need to be referred by their psychiatrist, or if they're not under the care of a psychiatrist, by their GP. And we review case notes, we talk to them, and then we talked with our team to make sure that the team is on board, and we provide psychoeducation. So over the years, we've seen quite a few women with mental health issues, or actually psychiatric disorders with onset around the perimenopause, either recurrences or like new onset episodes. And what I've observed is, like, as I said, bipolar disorder seem to be strongly triggered by childbirth, and sometimes this disease can be called postpartum psychosis. And many women with this type of bipolar illness, with like onset after childbirth, then they can be well for 10, 20 years up to the time of the perimenopause. And they come to our service sometimes with some antidepressants, without any mood stabilizer, or they are not under the care of psychiatric services. And I think that it is important to remember for these women, this is a period of increased risk, I believe. This is not what the study showed, because the study was on new onset, but in my experience, and also the data, taken together what we have, we can say that probably the period around the perimenopause is a period of increased risk also for these women. So antidepressants, monotherapy in women with bipolar disorder is never a good idea, like especially if women are not under the care of a psychiatrist. But especially at this time, I think we should prescribe them with caution. It's not that everything in the perimenopause is depression. I think this is the key, the take-home message. Like there are different disorders, and sometimes SSRIs are really not the best option, like for these women, because they can trigger episodes of mania or mood instability or mixed episodes. Even the most biological presentation, I think we need to take into account psychosocial factors. Like the late 40s, early 50s are periods of transition in role for many people, and also the family burden can change, and also aging sometimes existentially is a relationship related to that. So we should always, provide a holistic approach to our patients, not only considering the biological aspect of this. I get a lot of questions about HRT, and I don't think HRT do trigger mania or psychosis. We don't have any evidence for this. I think usually if we see that, it's because people start to be unwell, they go to the doctor, and then the doctor prescribes HRT, but they continue to be unwell until they develop a full-blown episode of mania or psychosis, and this is called prophylactic bias. So there might be, when there studies show an association between HRT and psychiatric disorders, I think the arrow of causality needs to be established. In my experience, HRT do not treat mania or psychosis, and they do not work instantly. So compared to other psychiatric medications, I'm thinking about especially benzodiazepine or antipsychotics, we need to get HRT time to work, weeks, if not even months. Sometimes, like the best treatment is not or might not be available, and this is true for HRT, but it's also true for psychotherapy, for example. Like we might say, oh, psychotherapy might work for you, but why do you get psychotherapists? Waiting lists are long, so always work with what you have. And in my experience, the care can be quite disjointed, and ours is a second opinion clinic, and I think there is really doctors might not follow up either because they're busy or because again, views on menopause are quite polarized. I think there are people that we tend to either overprescribe around the perimenopause or absolutely neglect big problems. So I think unfortunately the positions are polarized. So I think psychoeducation with patients become really important. Given that bipolar disorder, I think really, despite being a rare outcome, I'm not saying here that the absolute numbers of bipolar disorder with onset of perimenopause are not massive, but definitely there is a link between the two. So although major depression probably is more common, it's definitely more common. So the most probable presentations around the perimenopause of psychiatric disorder is either an anxiety disorder or a depressive disorder. Bipolar disorder is definitely on the rare side of the prevalence, but actually the link is quite specific, and the consequences can be devastating because people don't think that they can develop such a severe illness mid-age, in that phase of their life. And also, if, as I said, people have been well for many years, they don't think they can develop a new episode at this point. They might not be in contact with services. So I think I'm delighted to give now to introduce you to Claire, who is going to talk specifically about this link between bipolar disorder and the menopause. Thank you, Claire.
Great, thanks very much, Arianna. I will just try to share my screen. Oh, I managed it. Screen sharing. Oh, good. Start it off. Great. Smashing. Well, thanks very much, Arianna and Lisa, for inviting me to contribute to this webinar. And I think it's really important to recognise that Arianna and her team are one of the few groups of researchers in the country, or even possibly the world, who are focusing on this interaction between hormonal changes and mental illness. And as a woman with bipolar disorder myself, who has faced issues around the menopause, I am really extremely grateful to her and Lisa and to their collaborators for undertaking this really important work. Just to say, well, I've got these logos up, Bipolar UK and APP. I've been associated with these two charities for a while, and through them I've met countless women who, like me, are convinced that there is a connection between our mental health and changes in our hormones. Whether this is due to our menstrual cycle or being prescribed various contraceptive pills, the impact of pregnancy and childbirth, or even ending breastfeeding, or what we're focusing on today, perimenopause or menopause. But as we've heard, very little research has been done on this up until now. And it's only recently that public awareness has been raised about how debilitating and even life-changing menopause can be for many women, as Arianna was saying at the beginning. We've got more media recognition now, and at last attention is being paid in Parliament. And when it's realised that hundreds of thousands of experienced female workers are leaving the workplace every year because of unmanageable menopausal symptoms and the lack of support that they receive, politicians finally start to pay attention. For example, the UK Parliament's Women and Equalities Committee reported on this issue 18 months ago, and they quoted Bupa figures that almost 900,000 women in the UK had left their jobs because of menopausal symptoms. And they called for action to be taken to prevent this enormous brain drain as much as anything else. Unfortunately, nothing much has come about because of that, because the government rejected most of the committee's recommendations, but that has sparked a debate about the need to move menopause up the political agenda. And political and social change in terms of reducing the stigma around menopause and helping more women to stay in work would, of course, be welcomed by all of us. But for those of us with a lifelong mental health condition, the issue is even more critical. If you have a mood disorder, you have to learn to manage your life. You have to understand what triggers the extremes of depression or mania, so that with the help of medication and psychological therapies, you can avoid becoming dangerously ill. For women, this is massively complicated by hormones. You might be put at risk every month, or if you become pregnant or when you give birth. And I'm not talking about feeling a bit down for a few days, because 50% of women with bipolar disorder have a severe episode of illness after birth, for example. And half of those suffer a postpartum psychosis, which can put them and their baby in hospital for weeks as they're at high risk of suicide. And I mentioned the potential impact of childbirth because if hormones can affect us so dramatically at these times, it seems obvious that we would also be affected as we approach the end of our reproductive life around the time of menopause, with the massive changes in estrogen and other hormones that are occurring. But because this process is so gradual and individual, as Arianna was saying, it doesn't happen within days of giving birth like the postpartum trigger. Because of that, it's hard to predict and very difficult to recognise and even harder to deal with. And we desperately need more research on this, on the effect of menopause on mental health generally for all women, but especially for women with an existing chronic condition. For example, if enough was known about the impact of hormones on the brain, it could be possible to predict which women were likely to suffer a severe episode at times of hormonal flux, like childbirth or perimenopause. And that would be critical information for clinicians and women themselves to know. Such women could be forewarned of the likelihood that their illness might be triggered, and they could be better prepared for it. As a mental health researcher, I was aware of the dearth of quality research on this subject, but what there is, plus anecdotal evidence, indicated that perhaps women with bipolar, like me, were at risk of being triggered when our hormones started to fluctuate in perimenopause. So I acted proactively and asked my GP for HRT, or hormone replacement therapy. And this worked great for me. But looking at the internet forums of Bipolar UK and APP revealed that this is an issue that has caused serious problems for many women in a similar situation. And here are just a few examples from the Bipolar UK e-community illustrating the problems women with the diagnosis of bipolar can encounter, largely because GPs and psychiatrists don't receive training on the menopause and its possible interaction with mental health conditions. And this one at the top, I went through menopause early and it was missed by my GP because it was diagnosed as bipolar symptoms. I lost my job and everything. Psychiatrists completely ignorant about the matter. Just got HRT now at age 50 from GP, makes a real difference to how I feel. And this other woman says, I've been in perimenopause for nearly 7 years, but only realised a year ago. I begged for support from services for months. It took an overdose to be heard. 2 weeks ago, my doctor agreed to HRT and it's changed my life. I was suicidal and had relationship issues caused by my manic behaviour. Now I'm making amends and trying to heal me and my marriage. And this last one about the problems. Mum first became unwell with bipolar symptoms when she was 51, triggered by menopausal hormone changes. Her GP prescribed antidepressants, which triggered hypomania, mania, and psychosis. And as you can see, this, as Arianna was saying about it, sometimes HRT not working for everybody, but she's explained that perhaps it isn't the HRT. Oh, sorry. But this lady obviously thinks that it was the HRT. Again, gynecologist put me on HRT a couple of years back. For me personally, it was a nightmare and caused major mood swings. In the end, a doctor advised me to stop it immediately. She thinks that her mood improved. I've learnt the hard way. Any kind of hormone replacement aggravates my bipolar. Obviously, we're all different, but for me, it was awful. So sometimes ignorance, can be the of what can go wrong is just sort of can be the worst thing, really. I think, sorry, I'm getting mixed up with my slides here. And as that comment illustrates, hormone replacement isn't the answer for everyone, but for me, that just highlights that the lack of knowledge on this subject, which is a result of the lack of research, is the real problem. I mean, why should women be begging their doctors for help and have to attempt suicide before they're listened to? Now, this lack of information prompted us to investigate the matter further as part of the work of the Bipolar Commission. And we dedicated one section to the largely ignored issues that specifically affect women with bipolar and launched a survey to gather information on the questions that mattered most to them. And the survey attracted over 1,000 responses and gave us some valuable data on just how much hormonal change affects the course of bipolar for many women. And we asked about the perimenopause and menopause. And the majority of respondents, 58%, said they didn't know that this stage of life could carry a higher risk of their bipolar being triggered. And this is probably because 89% of women said they had never been told by a health professional that they were more likely to have an episode at this time of life. Yet of those in the relevant age bracket, over half said perimenopausal or menopausal symptoms had impacted their bipolar, and 28% of those said the impact was significant. So many women themselves believed that the problems they were having were linked to the hormonal transition they were going through, but few were offered hormone replacement therapy, which is the recognised treatment for menopausal symptoms. And this is a serious missed opportunity, as so many women testified that HRT had helped them tremendously and greatly improved their bipolar symptoms. Of those who reported taking HRT, 64% said it had helped them, with 21% saying it was extremely effective. So no wonder that 88% of women in our survey think that healthcare professionals need more training in this area, a suggestion that was endorsed by the UK Parliament's Women and Equalities Committee, but batted away by the government in their response. So it's something that we will have to keep fighting for. So meanwhile, for women who want to find out more about this subject, here are a couple of resources: the Bipolar UK webinar on the subject and some information on the APP website. And if there are any other researchers watching this who are interested to conduct studies in this area, all I can say is please do. I'm sure you'd find lots of participants willing and eager to help you. Thanks very much. I'll hand back to Arianna. Stop sharing.
Thank you, Claire. That was fantastic. Thank you. So we received a number of questions, both in the Q&A and in the webinar chat. A question for Kat and Ellie. Will we be able to answer, if we can't answer now, through email? Do we know how we can answer if we can't, like remotely, not today, if we can't go through all the questions?
Previously, Arianna, we've put some responses in a blog and kind of linked, got back in touch with everybody that registered for the webinar. So that's a possibility. It's tricky. Not everybody shows their email addresses, but if what we can do is share your contact details as well, as long as the panels have contacted about certain.
Oh, I'm happy with that. Yes, and we will do the blog thing if people want, so they can come in touch with, they can get in contact with us. So I will start, and I will go, in chronological order. So, how does the menopause affect bipolar disorder? I think, Nikki, thank you. We've been through this a bit. I'm not sure if we've answered your question enough. It's a bit like what Claire actually said in terms of symptoms. I am not totally sure we know what happens in the brain in biological terms. But Claire, I would say from your results, right, it does not everybody, but many people are affected with bipolar disorder by menopause, right?
Yeah, definitely. And I think the thing is for us to try and get the information out there to women to at least be aware of it themselves, so that they can, be slightly have it in the back of their minds when they get to that sort of age. So that also the problem, I think, is quite often that people, if they get mood symptoms, then they're going to immediately think that it's bipolar, and so is their GP, or so that's in my experience, that's a big problem for women, because as soon as they go saying I think it's the menopause, their GP says no, I think it's your bipolar, and that's a problem. That's why we so desperately need more research about it, so we can prove to the professionals that it's quite likely to be the menopause that is triggering problems.
Thank you, Claire. There are a couple of questions on HRT and surgical menopause, and again, Lara asked whether surgical menopause can trigger depression, and although we exclude from our study women who had surgical menopause, I think the answer is yes. It can. There are cases, of course, and HRT can help definitely. Again, compared to non-surgical menopause, the surgical menopause is quite abrupt, so you have abrupt changes in your hormone, which make things a bit more, I think, difficult. I'm trying to go through question. So Tia asked a couple of questions, I think more for Lisa. And Lisa, do you want to answer to the questions?
Yes. So I believe the first question that they asked, also thank you for the question, was information about the perimenopausal period gathered from the UK biobank, so the data that we were using, and was a specific age range selected, or does the biobank have specific information on perimenopause? So that's a really great question, actually, because a lot of previous studies just use age. So because the sort of median age for the final menstrual period in the UK is around 50, a lot of studies will just sort of look at around 50 and sort of use that as a proxy for menopause. Whereas in reality, in our study and many others, we can see that the variation in menopause age is really large and varies a lot between women, and so does the length of the perimenopausal period. So for example, in our study alone, we have over a 20-year range of different ages at final menstrual period. So we do, the UK Biobank specifically asks women if they've had menopause, and if they have, at what age. I think I actually have the wording here. Yeah, how old were you when your period stopped? Only if they also said that they had reported a menopause. And so from this, our study uses that as the age of the final menstrual period, but then does a sort of plus or minus 2 years, because it's really quite likely that that will capture at least some of the perimenopausal period. That's also why we have a little bit of a sort of gap of, is it 4 years? Before looking at the premenopausal period, to try and make sure that the premenopausal period is much less likely to capture some of the perimenopausal period. But it's both the limitation and the strength of our study, in that we do have the age that they report menopause happening, which is a huge boon over the vast majority of research that probably diminishes the sort of reporting of how many people experience problems, because it's not accurate to the individual and the timing of their menopause. However, unfortunately, the biobank doesn't have, for example, all of the sort of clinical criteria about exactly when the menopausal transition starts. So I think future research would really, really benefit from having a lot more information about what people's symptoms are, about their cycle length and the variation, and all these other factors that would much, much better allow us to understand the biological timing and reproductive timing of each individual woman. So to answer your question, short answer, yes, we did have an age, but no, it's unfortunately far from perfect, and it's something that research really needs to sort of crack down on, I think. And then the second question they asked was, we know most mental illnesses have a significant age-related distribution. Is there a comparison available in males in the same age groups to check this is not linked to age and is specific to perimenopause? So this is actually a sub-analysis that I ran, looking specifically, sort of matching each participant to a male participant, to see if we could see the sort of same pattern in males, which would be quite a good control. That did vary a little bit between disorders. I think Arianna was already mentioned that I think our things like depression was a bit more convoluted, but for all the disorders at perimenopause, the females had a higher ratio of at perimenopause compared to pre. And for mania, at the sort of perimenopause equivalent age in men, there was no association. So for mania, which was our sort of the result that we're kind of the most interested in, given what we found, there was no association in males, which is quite encouraging to know that it is likely related to menopause, and that the future research in that area is likely to be a bit more robust. So yeah, thank you for those questions. I'll hand back to Arianna.
So how are we doing here for questions? Many coming. I think you can look for the effects of those on hormonal contraception, Lisa. In your study, we are working on controlling for hormonal contraception, right? Yeah, the paper should be hopefully out in the next couple of months. So we'll make sure we'll post a link on that as well. With a previous postpartum psychosis and subsequent bipolar, are there any HRTs that should be avoided? Miranka, I think, again, to Teresa's question, which is about HRT and postpartum psychosis and bipolar disorder, I think it's really up to the individual. Unfortunately, we don't know. There are not randomized controlled trials, as far as I know, about bipolar disorder and HRT, so let alone different types of HRT. I think it's always worth to try HRT, and then of course close monitoring. The important thing is to recognizing the risk. And I think if you recognize the risk, when we see problems usually in psychiatry, it's because people can't get access to services. But once people can get access to services, I think you can try medications, knowing that we don't know much. But I think it's always worth giving it a go. Very important as a message for today, I think is really, really important. Severe mental illness, there is no evidence that it can be treated with HRT. And I think that would be a very dangerous, path to think that the sole use of hormone replacement therapy can treat an episode of severe mental illness like psychosis or mania. Those require usually very robust psychiatric treatment, and unfortunately, in most severe cases, often hospital admission. So we don't want to trivialize, of course, those disorders. On the other side, like depressive symptoms related to the menopause might be, or insomnia or symptoms of fasciitis related to the menopause. Those are not necessarily psychiatric disorders. So, that distinction is really difficult to make, but I think is also really important to distinguish. And history, patient's history, I think is very important.
We're hitting 1 o'clock, Arianna.
Oh, okay. So I think, we can answer all the other questions, I think, through a blog, Kat, if that is okay. Claire, Lisa, any final word from you?
No, just thanks again for getting on with this research. We need more of it.
Fantastic. Thank you.